My name is Rashmi Halkar Singh, and I'm the Deputy Editor of the Headache Journal. I am joined today with Dr. Jessica Ailani, who is one of the authors of one of our recent submissions, which is, does wearing off of efficacy occur in Galcanezumab-treated patients at the end of the monthly treatment cycle, post-hoc analyses of 4 phase 3 randomized trials. So welcome, Dr. Ailani. I'm really excited to talk to you about this manuscript.
Thank you. Thank you so much for inviting me on behalf of my authors. We're really excited to be highlighted. And it's just so awesome to spend some time chatting with you.
So first of all, can you tell us about this paper? What's it all about?
Yeah, so this is a very clinically driven article where we had this question in mind, and by we, I mean many of us had this question in mind. And Andy Blumenfeld is one of my co-authors on this paper, and we really were pushing to take a look at wear off. This idea that when you're on a monoclonal antibody for prevention of migraine, that patients were coming into clinical practice and stating that, you know, at the end of the time period when they're due for their next injection, that a portion of patients were describing a phenomenon where they had worsening of migraine, or in some cases, the only time they would experience any migraine in the portion of a month. And so clinicians were starting to talk about wearing off. What does this mean? Does it exist? Is it in every patient? What's the risk? And when you look at the literature, it's really unclear what wearing off is. How often is it happening? Is it even happening? There were some studies taking a look at fremonizumab, and there's some studies that are looking at arenumab, and you look at the clinical trial populations, and even Galcanezumab took a look at their clinical trial populations, and they really weren't finding this idea of wearing off in clinical trials. And part of my argument was, that's a clinical trial. Those are not the patients that we're necessarily seeing in practice. The clinical trial population, first of all, are not patients that necessarily have tried many options before. Whereas in clinical practice, the patient who's getting started on a monoclonal antibody, especially early on, who's been on treatment for a period of time, is someone who has tried preventive options before, considered potentially a more refractory patient. And sometimes it was this more refractory patient population that potentially was having this wearing off effect. Also in a clinical trial, patients were coming in very regularly, keeping a calendar, were getting a dose every 27 to 28 days. There was no insurance hassle. There was no forgetting to take your medication. Everything was being followed to a T. And in real life, this is not what's actually happening. So potentially wearing off had other factors contributing, like patients not being adherent to their medication, medications being switched at the pharmacy, delay in medications actually getting delivered. But this is not really easy to study. Real world studies can be messy, can be really hard to undertake, and really follow patients over time. So speaking with the company, we came up with this idea. One, we need to define what wearing off is, and we need to take a look at a population base in these trials, look at all the trials that Lilly has with galcanezumab, and see if we can identify, is there a particular patient type that is wearing off? And not just looking week to week, but looking at the end of the treatment period, which is the 4th week, comparing that to the 2nd week of the month, which is about a week after galcanezumab got into the system. So we wanted to define what wearing off was and see in any of the trials looking at galcanezumab, whether that was their episodic migraine trials, their chronic migraine trial, or what's considered their more refractory migraine, their Conquer trials, in episodic or chronic migraine patients who had tried 2 prior preventive treatments at least and found them ineffective. In any of these patient populations, were we seeing this wear off incidence occur with any statistical significance? So that's the really lowdown of what we looked at. And it was really thought over. Can we prove what we're seeing in clinic is actually happening?
So these are patients who found the medication to be effective. They felt like it was helpful for them. And then you look to see if there was any sort of this wearing off phenomenon. Am I summarizing that accurately?
Yes, we actually looked at all comers and we looked at those that found it effective. So we looked at both groups of patients. So was there any change in headache frequency in both these groups of patients? And we wanted to see the wear off phenomenon, which we really thought was if you had a change of 2 migraine headache days per week, an increase from weeks 2 all the way to week 4, that would be considered a wear off. So there was an uptick in your migraine frequency during that time period.
I think this is such an important question, and you're absolutely right that this comes up in clinical practice all the time. I mean, just today, I had this conversation with my patients who asked me about possibility of wearing off with their monoclonal antibody medications. I mean, it was different medications, and they were concerned it was happening, and I had to, have that conversation with them. So, what did you find? What were your results?
Yes. So no matter which way we cut the information, we actually did not find wearing off occurring in the patient populations. We did, after a lot of pushing from our clinical, pushing side, we did take a look at these patients with chronic migraine that were refractory to treatment. And numerically, it looked like there might be a difference in this patient population, that there was a potential numerically that they might have a little bit higher chance of wearing off compared to other patients who were on galcanezumab. This wasn't statistically significant. What I really think that means is we just didn't have enough patients in the clinical trials that were like that to see that difference. And so, from a study standpoint, that means we didn't find the difference. From a clinician standpoint, if I were to take this information, it just tells me that if I were going to think about wearing off, it goes back to the patient that's more vulnerable in a headache practice, the patient who's refractory, the patient who's got chronic migraine, the patient who's tried lots of things and they haven't worked. And in that patient, really being very direct with them about sticking to their regimen, trying to keep to the every 30 days, not, forgetting to pick up the medicine or picking it up and leaving it out and then taking it a few days later, not trying to get behind insurance authorizations, and really putting the power of authorization back in their hands. So in our clinic, we're very big about telling the patient, just keep up to date with when your authorization is going to come up for renewal and send us a message and we'll get it done. But, you can't rely on us to be reminded by the pharmacy. It doesn't always work like that. And this is an important treatment for you you're doing well on. So we need to make sure that you keep up to date with this stuff. And I have found that sometimes can help with a bit of the wearing off effect, especially in those more vulnerable patients. We need a lot more work on this because I don't think we've quite answered wearing off. And there's still a lot of question around, is it really wearing off or is it natural history of disease? Is this more vulnerable population that I'm talking about, our refractory chronic migraine or just even refractory episodic migraine group? Are they the patients that have that natural history of a lot more bumps and valleys in their disease, that they're going to have times that are going to be more severe and there's not much that we as clinicians can do except talk to them about pain psychology and working through catastrophizing and coming up with patches to get them through difficult times, as opposed to constantly changing their preventive treatment. This is extremely frustrating for us, but I think it's really still a question that's not quite answered.
Well, I think that's really important information to share. And I think that's really helpful as well as we try to navigate this next step in trying to see how we can help our patients, because these monoclonal antibodies have, made such an improvement in the way we can manage migraine, and helping our patients, through this next question as they manage their disease process is really important as well. So thank you so much for, sharing this conversation with me. I think this is really helpful to our audience. And thanks so much for publishing this paper with us in Headache.
And thank you for having us, and thanks for accepting our paper. We really hope that our audience of clinicians and headache specialists enjoy this article, and it really helps you have that dialogue with your patients about wearing off and refractory disease. And sometimes this is just the roller coaster of migraine, as Richard Lipton would always tell us and teach us.
Absolutely.